Good morning. If you could please take your seats. My name is Nizar Jarjour. I'm the Division Chief for Allergy, Pulmonary, and Critical Care Medicine. And on behalf of Dr. Page, who couldn't be with us today, it gives me a great pleasure to welcome you to the Pulmonary Medicine Grand Rounds. Our speaker this morning is Dr. Bill Ehlenbach, one of our very own. He's an assistant professor in the Division of Allergy, Pulmonary, and Critical Care Medicine. And he has been in Wisconsin for quite a while. Dr. Ehlenbach earned his bachelor's degree from the University of Wisconsin-Madison and had focused at that time in molecular biology and philosophy. After that, he did his residency and chief residency at the University of Wisconsin Hospital. Following that, he went to Seattle, where he did a Pulmonary and Critical Care Fellowship at the University of Washington. Including there is a research fellowship and a Master of Science in Epidemiology. During his fellowship and following that, he developed expertise and interest in outcome post-critical care illness and the outcome of cardiac arrest. He has earned a number of awards and recognition during his training, and after that we'll mention a couple of them this morning. The first is University of Wisconsin Patient Experience Physician Champion Award. As you know, UW Health Physician Champion Award is given only to the top 5% of physicians who earn the recognition based on patient survey. Another award he received is the John Peterson Award for Humanism in Medicine. This is given by our palliative care medicine once a year to a physician who has championed issues of end-of-life care. His work is supported by a very prestigious grant from the National Institute of Aging. It is a Beeson Award given for physicians who are doing research related to aging, and his work is in outcome post-critical care illness in aging. He has had a national recognition in the area of outcome post-critical care illness based on a number of very high-profile publications, including publication in JAMA and New England Journal of Medicine that dates back even to his early days in training. This morning, it's our pleasure to invite him to speak to us on DNR, what it means, what should it mean, and how we talk about it. Please help me welcome Dr. Ehlenbach.
Thank you very much, Dr. Jarjour, for the kind introduction. Very happy to be here on the first real Wisconsin day of the year. And for the interns that might have moved here from elsewhere, welcome to Wisconsin. So as Dr. Jarjour said, I'm going to talk about DNR, which is something we encounter every day, but my hope is to make you think about it a little bit more and perhaps a little bit differently. So I want to talk a bit about the history of DNR orders, describe the importance and appropriate scope of Do Not Resuscitate orders, and talk a bit about how to discuss CPR and DNR orders with our patients. So I like medical history. I like history in general. And I want to start by talking about this paper, which was published in 1792. So in the late 18th century in European medicine, there was quite a bit of interest in drowning, hypothermia, and suffocation. And James Curry published this article where he outlined, really laid out some concepts that not everyone who seems dead is dead, which I think is interesting. So we talked about a recoverable apparent death, that which only lies dormant, and the later development of absolute death, which he described as death in which the vital principle is completely extinguished. So as I said, this was an area of interest in the late 18th century, remained an area of interest in the 1970s, studied by Monty Python, and we see Miracle Max from The Princess Bride, who describes that your friend here is only mostly dead. Mostly dead is slightly alive. By the late 19th century, so approximately 100 years after that paper, we had some early reports of things that we might recognize as chest compressions. So we have a paper that James Hill published in 1868, where he describes the surgeon's left hand was placed firmly across the front of the chest, the right hand crossed over the left, forcible pressure is made, the hands being suddenly removed, the chest was allowed to expand by its own elasticity. We recognize that, I think. And actually in 1792 in Germany, a case report that describes what I would say is maybe cardiac arrest, where they did something like chest compressions and the patient was revived. George Washington Cryle, who was the founder of the American College of Surgeons and actually one of the founders of the Cleveland Clinic, described a case series of chest compressions that he published in 1903. And again, some of these were apparent successes. Again, it's unclear exactly what those patients were suffering. Much of this work was forgotten in the early 20th century, but by the mid-20th century, there was an uptick in research. And one of the first areas of really very significant research, particularly in the 1940s, was research on defibrillation. The motivation for this and much of the funding for this work actually came from the electric companies, right? So the United States was rapidly electrifying, and workers were rapidly being electrocuted. So they were interested in developing techniques, and so there was a lot of animal work. What happens with electrocution, what happens to the heart? There was an understanding of the role of electricity, and so internal defibrillation was described in humans in 1947. Paul Zoll, that's a last name that we recognize, right? Our defibrillators in our ICUs are Zoll defibrillators. Published in 1956 on successful external defibrillation, so applying electricity to the chest. They were using quite a bit more energy than we would be comfortable with today, somewhere in the 700 joules range. If you're going to give it a try, you really want to. Peter Safar has been described by many as one of the sort of founders of critical care medicine as a field and one of the developers of some of our modern concepts of resuscitation. He published on mouth-to-mouth resuscitation in 1958. He is the one that developed and popularized the concepts of the ABCs, so airway, breathing, circulation. And actually quite early on, he thought that mouth-to-mouth resuscitation should actually be taught to people in the community. He thought this was something that could be used on a widespread basis. But really, the paper that is usually thought of as the beginning of CPR as we know it was published in JAMA in 1960. And it was entitled Closed Chest Cardiac Massage, which sounds lovely. And in many ways, this first describes chest compressions as we really do recognize them. In fact, this is a figure from that paper describing the position of the hands, the position of the operator. And again, this figure is position of hands during massage of the adult. It sounds much less violent than it actually is, right? And one thing I want to point out in this paper is what the outcomes were that these authors described. So they reported a 10-month case series, essentially. And during 10 months, they had done closed chest cardiac massage on 20 patients. The youngest was 2 months. The oldest was 80 years old. In 13 of these, there was also some ventilation supplied. All 20 patients had return of spontaneous circulation. Okay, that's interesting. And at the time of writing, so for some of these patients as long as 10 months out, 14 of the 20 were still alive. So what were they really describing? They were describing in entirety, all of their cases were perioperative or peri-anesthesia cardiac arrest. So these were witnessed arrests that were immediately reacted to. And in all of these cases, there was either the initiation or induction of anesthesia or something about the surgery itself that actually led directly to cardiac arrest. So this was a huge paper, and as a practice, CPR was taken up widely very quickly. So the American Heart Association formed a CPR committee in 1963. There was a paper in 1964 describing what was then an incredibly controversial topic, which was, can ambulance personnel provide CPR? And the answer this paper suggested was yes. By 1972, you had a group in Seattle training 100,000 civilians to perform CPR. There was a national conference on CPR sponsored by the National Academy and the American Heart Association in 1966. And very quickly, CPR became viewed as the default response to cardiac arrest, wherever and whenever it occurs. So as CPR became widely used, particularly in the hospital, people noticed that their outcomes were not like what had been described in those early papers, right? It wasn't 20 out of 20 people with return of spontaneous circulation, and it wasn't 14 of 20 with some degree of long-term survival. So the outcomes were far worse, and a number of people started publishing on what survival to discharge rates looked like when this was a widely applied intervention. And already by the 1970s, some practices around DNR developed, and some hospitals started to develop policies and procedures for official do not resuscitate orders. But as often happens, there were practices that were sort of moving in front of policy, and there actually wasn't. This was happening far longer and far earlier than it was actually published or written about. By 1983, President Reagan's Commission for the Study of Ethical Problems in Medicine endorsed the idea that DNR protocols are appropriate. They're a way to respect a patient's right of self-determination. So I want to step back a moment and just think philosophically. Why do we need do not resuscitate orders? I don't want to be the person to break bad news in this context, but everyone in this room will die. And physiologically, I hope this is a non-controversial statement, death is preceded by cardiac arrest 100% of the time. So even before we know any statistics, unless we believe in physical immortality, some proportion of cardiac arrest is irreversible. And what we know from practice is that CPR doesn't change the fact that a dying patient is dying. We don't always know that a patient is dying, but we often do. And so we need DNR orders because not all patients with cardiac arrest should receive CPR. So DNR orders are necessary, and I would argue very important. But do they work? And by that I mean, so DNR orders as a concept are older than I am. Have they accomplished the goal? Have they improved our delivery of patient value-sensitive, preference-sensitive care? Have they eliminated the delivery of CPR to patients who are extremely unlikely to benefit? And I think there's plenty of evidence in the literature and probably many of anecdotal experiences that we've had that tell us that DNR has been relatively disappointing. It actually hasn't accomplished some of the things we would hope that it could. So the support study was a huge randomized trial of patient communication intervention. But one of the interesting observations in this huge trial studying seriously ill inpatients is that half of those patients who had told the research nurse that they actually would not want CPR if they had cardiac arrest did not have a written DNR order. Many of them had CPR performed. We also know from a number of studies that the pattern of DNR use varies dramatically, hospital to hospital, region to region. And when you really dive into those data, it looks like it's physician factors and hospital factors that have a huge impact on whether a particular patient has a DNR order written or not. And it seems like those are bigger drivers than patient preferences. So that's, I would argue, a problem. We know that what a DNR order means actually varies quite a bit hospital to hospital. And so that creates confusion. What do we mean when we say DNR? So we know from our own experiences and from the literature that the delivery of CPR to patients with a very low likelihood of benefit remains common. One of the things I want to talk about is, are we really thinking about CPR the right way? Are we thinking about do not resuscitate orders the right way? So when we think about cardiac arrest in the hospital, when we talk about CPR, we're often thinking about survival rates, and that's often what we're talking with patients about. So we know from a number of large studies that survival to hospital discharge after in-hospital cardiac arrest occurs in about 15 to 18% of patients. And we know that there are some predictors of lower likelihood of success. It's lower for older patients, lower for men, quite a bit lower for patients with significant chronic disease, quite a bit lower for patients who were admitted to the hospital from a skilled nursing facility. But if it's just about survival, I mean, survival after cardiac arrest without CPR is 0%. So why not give it a shot? I would argue that low likelihood of survival, shouldn't be the primary motivation for do not resuscitate orders. And I would argue that we should think about CPR. It's not simply a choice between the small chance that we can save you versus the greater chance that it doesn't work. And I want to make the case that we currently think of CPR in a different way than any other medical procedure, but I think we should think about CPR like we think about any other medical procedure. And that I think we should think about CPR explicitly as a procedure with a potential for benefit, as well as a potential for harm. And we do have ways of trying to weigh the potential for benefit, the potential for harm in any given patient. But again, I think we're maybe perhaps stuck on the notion of survival. And I want to point out a paper. It's a very good paper, but one of the aspects of this discussion, I think, highlights some of the ways that maybe we're not thinking about this right. So this was a study that was published in the New England Journal in 2013. And they looked at Medicare beneficiaries, so these are individuals 65 years old and older, who suffered in hospital cardiac arrest and survived to hospital discharge. So that's already a special, and we know, small group to think about. And of those patients, they said 58.5% were alive at 1 year, and almost 50% were alive at 2 years. Those are important findings. Those are interesting findings, and those were novel findings. What they stated in the discussion is that our findings that almost 60% of patients were alive at 1 year challenge earlier assumptions. Although in-hospital resuscitation efforts in patients of advanced age may be perceived as futile, the relatively high survival rate among these patients suggests that discussions about advanced directives should be individualized and informed by patients' preferences and health status. Now, the last part of that I hope is non-controversial, and I hope we didn't need their data or any data to tell us that discussions about advanced directives should be individualized and informed by patient preferences and health status. But I have a problem with the notion that you can take this conditional survival to the patient's bedside and say, if you do well, you might do well. I mean, I would agree, this longer-term survival is better than I would have guessed, but I don't think it dramatically changes how we should think about the survival issue alone. So I actually wrote a letter to the editor. That was a little, So this is a table that we had in this letter to the editor, and we took data from a paper that I had published looking at survival to hospital discharge, and then looked at of those who survived, how many are alive at a year. And I would argue that it's really these survival numbers that if we're going to talk about survival with patients, and we're going to think about long-term survival, for individuals in their 80s, for the so-called very old group, if you have patients that had CPR, there's a 6% chance of being alive at a year. Now, that's not 0%, right? But it's not 60%. And 11% or 12% aren't 60%. So even I think we can even improve the way we think about survival. But it's really not just about survival. going to talk again about a few numbers here. So we actually know that almost half of patients with in-hospital cardiac arrest have return of spontaneous circulation. So this would be the successful code. And as the PG3 carrying the code pager, you often feel very good about these episodes of CPR. But we also know that less than half of those who have return of spontaneous circulation survive to hospital discharge. And we know that that patients who've had one episode of cardiac arrest are at risk for another, and that patients who survive, the likelihood of survival to discharge decreases with each episode of cardiac arrest. But again, so almost half with return of spontaneous circulation, and of those, a significant portion still die during that hospitalization. Another issue that for many of our patients, perhaps for many of us as we think about our own healthcare decisions, there are things that are more important than survival. We know that brain injury from hypoxic ischemic injury after cardiac arrest is common. And I would say at least 1/3 of adults surviving to discharge have significant disability. There are studies that suggest that even in the therapeutic hypothermia era, that it may actually be quite a bit worse than that. And 1 out of 10 have severe disability, persistent vegetative state, for example. And we know that neurological outcome is significantly worse for older patients, for patients with organ failure prior to arrest. That's a pretty strong predictor of a poor neurologic outcome. Those are the patients that I see in the ICU. Patients with sepsis prior to their arrest, patients with malignancy. And then I have in brackets here some features that you can't predict or know about before somebody has cardiac arrest, but we do know that longer duration of CPR, an initial cardiac arrest rhythm of pulseless electrical activity, or asystole, those are also associated with a poorer neurologic outcome. So I want to come back to the notion that CPR is like any other medical procedure, with a potential for benefit and a potential for harm. And potential harms, I think, we can make those explicit. We know that there can be pain and physical injury associated with CPR, with chest compressions in particular, with defibrillation. But brain injury with new disability is a very significant potential harm. And for many patients who receive CPR in the hospital, CPR merely postpones death by days, weeks, or even months in the hospital, which I have certainly seen. I want to talk about a case that comes from the medical ethics literature. This was a case published by Thad Pope earlier this year. And I think this case illustrates the notion of harms from CPR from the perspective of a patient or a patient surrogate. So in June 2013, Beatrice Weissman suffered a stroke in Maryland. And she had a severe decrement in her functional status. And in the several months afterwards, she really showed no improvement. She did not have capacity for decision-making, so her healthcare power of attorney filled out a medical orders for life-sustaining treatment, or MOLST, similar to POLST in most states. So filled out a MOLST document, and included in that was a DNR order. And then something happened that I think many of us have seen, which is that despite having a DNR order, she suffered a cardiac arrest during a hospitalization 4 weeks after the DNR order was written, and CPR was performed. She had chest compression, she had defibrillation, she had epinephrine. And I don't want to focus on the systems issues that led to CPR being performed in a patient who's DNR, although those exist in many places. Now, she actually survived to discharge, and actually survived for years. So again, in the world of CPR outcomes data, we might think this is a success. In July of 2016, her family sued the hospital for assault, inadequate informed consent, and intentional infliction of emotional distress. And in the filing, they actually included this bit from her family. She suffered painful medical interventions at the end of her life in violation of her express wishes to the contrary, and will spend the remainder of her life in a condition repugnant to her values and wishes as to how and when she wanted to die. So for her, prolonging a state of existence that really was not acceptable to her was the harm of CPR. So for most patients, discussing do not resuscitate orders should center around the likelihood of good outcomes and the likelihood of bad outcomes. Because of respect for patient autonomy, because we respect a patient's right to self-determination, the patient's values and goals are incredibly important in defining what's a good outcome or what's a bad outcome or an unacceptable outcome. I think there are other contributors to what some have called the failure of do not resuscitate orders. One is that conversations about CPR and DNR are often not held, even in patients who are at risk for cardiac arrest or elevated risk. Literature suggests that DNR discussions and DNR orders are often initiated very late in the course of an illness, and often when a patient has lost capacity for decision making, which means that we perhaps have lost an opportunity to have the conversation with the patient, him or herself, but we've also placed a burden on the surrogate decision maker who might struggle with this decision. Even when CPR and DNR are discussed with patients, the discussion is often inadequate, and we've all seen this, we've all probably done this. I know I have had inadequate discussions with patients or with families. And the last point here I'm going to spend a bit more time on. I think remains significant confusion about what a DNR order actually means. Part of this is what I would argue is an assumption that patients with a DNR order, that automatically we can assume that they have other preferences about therapies or life-sustaining treatments, and we can just make that assumption. So plenty of studies suggest that patients with do not resuscitate orders receive less aggressive, less invasive care. So less invasive mechanical ventilation for acute respiratory failure, less hemodialysis for acute renal failure, much more likely to receive a palliative care consultation. And all of those things might be perfectly fine if it's actually being driven by patient preferences, right? And it's reasonable to think that some proportion of patients who prefer to be DNR also prefer to forego some of these other medical interventions. But I don't think it's actually patient preference that's driving a lot of this. I want to talk about 3 different studies, all of which were nationally representative survey studies. And in these studies, the respondents were asked to consider hypothetical patient scenarios and were given really identical scenarios with the difference being DNR status or not DNR status. So when attending physicians were surveyed, the patient scenario that had a DNR order, that patient was much less likely to be transferred to an ICU, much less likely to be intubated, and to a lesser extent, less likely to have blood cultures drawn for an infectious workup, less likely to receive a blood transfusion when indicated. It seems problematic. But maybe it's just the attendings, right? They don't really do this stuff anyway. But when we ask the medicine residents, again, similar patient scenarios differing by DNR status, those residents indicated a much lower likelihood of pursuing dialysis for renal failure, pursuing bronchoscopy where indicated, consulting a surgeon, transferring a patient to the ICU. I would argue that's a problem. Critical care nurses, in another survey study, significant majority, 72%, thought that a DNR order should limit aggressive interventions, and 65% thought admission to an ICU was inappropriate with a DNR order. There are common questions and confusions about what a DNR implies about other treatments. So, for example, what about intubation in the absence of cardiac arrest? Should we treat septic shock in a patient with a DNR? Can we consider cardioversion for dysrhythmias? And there are hospital policies and procedures that can significantly exacerbate these confusions. One of those that I'll talk about a little bit later is this notion of a la carte or partial DNR orders, which until a couple weeks ago we had in our system. So, summarize some of the things I've touched upon that have contributed to the so-called failure of DNR. One of those is the failure to think about CPR as a procedure with benefits and harms. One of these is the failure to talk about CPR, DNR to many patients at risk of cardiac arrest, and also some shortcomings about communication, and some confusion, and in particular ambiguities of policies and procedures that can contribute to this confusion. So I want to spend some time talking about the new Do Not Resuscitate policy at UW that I was involved with others in crafting, because I think it's a way of talking about what I would consider the appropriate scope of DNR, and to provide some clarity on what DNR does and does not mean. So formerly the hospital policy was 8.23. We now have a UW health policy, so comprehensive policy in all settings. That is number 1.2.13. I have no idea why. It is entitled Do Not Resuscitate. And I think there are significant improvements in the previous policy. So I think that this new policy defines the appropriate scope of Do Not Resuscitate orders, outlines how decisions to write a DNR order is made. So I want to talk about the appropriate scope of DNR. And I think one way to answer a question, if you find yourself asking, does DNR affect decisions about X or Y or Z, is to remind yourself that a DNR order only affects one clinical situation, cardiac arrest. So if you find yourself thinking, does the DNR affect anything else? Is the patient in cardiac arrest? No. Then we're not talking about the DNR order anymore. A DNR order should be thought of as a binary order. Full code means that in the event of cardiac arrest, any and all components of cardiopulmonary resuscitation, so all the appropriate components of advanced cardiac life support, will be used as appropriate. DNR, Do Not Resuscitate, means that in the event of cardiac arrest, none of the components of ACLS will be performed. There have been advocates in the literature for changing the term DNR, and I'm sure many of us have seen. So in some hospitals, DNR has been changed to Do Not Attempt Resuscitation to try to get away from the notion that CPR is always successful. There are institutions that have termed it Do Not Resuscitate / Allow Natural Death, which I think is problematic because then that starts to imply comfort care. And the United Kingdom actually changed, NHS changed the title of DNR in 2014. So it is now called DNA CPR, Do Not Attempt Cardiopulmonary Resuscitation. But in this policy, we continue to use DNR because it's the most widely used, and we use DNR as a synonym for no CPR. DNR does not affect therapies, even therapies that are similar or identical to components of ACLS when those are used for indications other than cardiac arrest. So for example, a patient with a DNR order who has a perfusing ventricular tachycardia, unless you know something else about the goals of care and a patient's values and even treatment preferences, we should assume that cardioversion for treating that perfusing ventricular tachycardia is on the table because the patient's not in cardiac arrest. Intubation for respiratory failure. Again, in the absence of other understandings of a patient's goals. The DNR order itself shouldn't tell us that we would not intubate a patient who has respiratory failure. Another therapy that we use in ACLS, but we use in other contexts, epinephrine. Again, patient who's DNR doesn't mean we won't use epinephrine for anaphylaxis or won't use epinephrine in the context of septic shock. So I want to then tackle an issue that I think is probably in many of your minds. Well, what about intubation? And I would argue that, okay, we know that there's similarities in process, and often when we talk about calling a code, sometimes we mean a patient who's in respiratory distress, and often we mean a patient who's in cardiac arrest. But I think that DNR and preferences about intubation really need to be considered separately. One reason they should be considered separately is that outcomes are very different. The whole risks of benefit, risks of harms, it's very, very different for intubation than it is for cardiac arrest. So, for example, probably upwards of 60% of patients who are intubated during a hospitalization survive to discharge. That doesn't mean intubation, delivery of mechanical ventilation, and other life-sustaining therapies aren't important things to talk about. I'm just arguing that's different than DNR, and it's different than CPR discussions. Of course, there are patients who, as part of a goals of care conversation, may elect not to undergo intubation and mechanical ventilation under any circumstances. And we do have within HealthLink at University Hospital the ability to write a DNI order for these patients. If you have a patient who wouldn't want intubation under any circumstances, it would not make sense to do CPR in the event of cardiac arrest for that patient. And so those patients also should have a DNR order. And actually HealthLink, as the orders were rolled out a couple weeks ago, will not allow you to write a do not intubate order for a patient that doesn't have a DNR order. A patient may be DNR, but not DNI, and I think that's going to be the most likely scenario, which would again mean that a patient who is DNR and has respiratory failure, intubation is on the table. The DNR doesn't affect that. I want to talk a bit about what I would describe as a la carte DNR. This is DNR from the takeout menu. So the new policy at University Hospital, or UW Health policy, and the new HealthLink orders does away with the partial DNR, which I think is a very good thing. One of the problems with partial DNR is many of the end users of those orders don't actually understand what that means. There was a lot of confusion about patients that had a partial DNR tag. I think there's even an even more important reason to get rid of partial DNR. And I want to give you the example of something I've seen a number of times, which is that a patient doesn't want chest compressions, but they want other aspects of CPR. So let's think that through. So you have a patient found in cardiac arrest, get them on the monitor, they're in asystole. They've got a peripheral IV. We're going to push some epinephrine. And then they're going to die with some epinephrine in their arm. That's not CPR. So I would argue that that sort of combination is illogical. And what we're really doing there is we're doing a sham code. Or a slow code. These are not ethically acceptable things to do. I think that these partial DNR orders contributed to ambiguity and confusion about the appropriate scope of DNR. And I also think that notion of partial DNR, do you want this? Do you want that? Do you want this other thing? Really lends itself to a treatment-based discussion rather than a goals-based conversation. And I think the more we dive in trying to talk to patients about their preferences about CPR and DNR, or their preferences about medical care in the context of advanced illness or an end-of-life setting, the more we dive into the details, the more we dive into the weeds, the lower quality these conversations tend to be and the less value they tend to have. So if I'm separating DNR from other aspects, other invasive or life-sustaining care, I'm not arguing that we have a DNR conversation, and then we have an intubation conversation, and then we have a dialysis conversation, and then we have a vasopressor conversation. Conversations about code status should be understood as part of a broader conversation about the patient's goals of care and what we can and can't do to accomplish those goals. And then the conversation can really be focused on how we can achieve the goals that they do have, rather than just talking about what we are or aren't going to do. So initiating a conversation doesn't have to be, you don't have to start out with a discussion about the heart or cardiac arrest, but putting in the context to a larger conversation. Some goals of care conversation starters, these are drawn from the Onco Talk, Code Talk curriculum that Tony Bach and Jim Tulsky and Randy Curtis and others were involved in. In a clinic setting, even in the setting of a hospitalization, it could be appropriate to ask a patient, do you have particular concerns about what's happening to you right now? And that what's happening might be this severe pneumonia that they have, or it might be the new diagnosis of cancer, or it might be the fact that this is their 4th hospitalization in 6 weeks. A way to ask permission to start having this conversation, this larger conversation about goals. We're working hard to get you better. I hope for the best, but many of my patients also want to prepare for what happens if this treatment does not work. I wonder if you've ever thought about this. And in the bottom, I think, is perhaps one of the easier openings for a patient who's hospitalized. I try to talk to all my patients in the hospital about what they would want if they become sicker. Have you ever thought about this? Those conversations can and often will and should, in many cases, lead to the specifics of CPR. And I think it's, of course, appropriate to inform patients about what CPR is. And one phrase that I often use to move away or to avoid getting into that treatment by treatment or intervention by intervention specific conversation is I describe CPR as a bunch of stuff we do together, right? A bundle of interventions for a patient whose heart has stopped, which includes repeatedly pushing down firmly on your chest, using a mask or tube to help you breathe, using electric currents from a defibrillator to try and restart your heart, using medication, often given into the veins, in order to help restart your heart. And this conversation should discuss a range of outcomes in the context of this patient's acute and chronic health conditions. And that outcome discussion should include the likelihood of benefits and the likelihood of harms. And in many cases, it's very appropriate to be explicit about what sort of harms are we talking about. It's not just there's a chance you live, there's a chance you don't live from CPR. So being explicit is often appropriate. As we talk about goals for treatment, and put CPR discussions in the context of these larger discussions, it's certainly helpful to try to understand the patient as a person, understand what they enjoy, what makes life worth living, if there are goals that they want to achieve. And again, the notion of focusing on general goals is appropriate, but of course it's also very appropriate sometimes to talk about goals in the context of specific treatment preferences. Patients often provide opportunities or openings for us to dive deeper. And when you explore patient statements about treatment preferences, for example, if a patient begins a conversation by saying, I would never want X to be on machines or whatever it is, if you explore those further, it really can inform you not only about a patient's goals and values, but also test a patient's understanding about their health care, these interventions. I think it's important to identify what life situations the patient would not find acceptable. So going in and out of the hospital every month to some patients would be fine, to some others would not be acceptable. One thing that I hear often from older patients in the intensive care unit is the notion of living the rest of their lives in a nursing home. Another patient, their unacceptable quality of life would be if they couldn't watch the Bears lose every week. I know that's important to me. Of course, the Bears probably aren't going to lose this week because they're playing the Packers. But so I would argue that when we talk about CPR or DNR, and when we talk about other life-sustaining treatments, we are less likely to make recommendations than we are in many other settings. And sometimes it feels uncomfortable when you're talking about life and death issues to make recommendations. But I think that as healthcare professionals, I think we actually have, as physicians in particular, I think we have a duty to make recommendations. And there was a very nice essay published in JAMA about 5 years ago that outlined kind of 3 different categories of how we approach DNR discussions, 3 different scenarios, if you will. And I've outlined them here as 1, 2, and 3. And 1 is there are plenty of situations in which we should discuss CPR as a plausible option. This is many of our patients. So when relative benefits and harms are uncertain, or for patients where you think the likelihood of a good outcome is pretty high. So for example, if you had a patient with a pretty good health status, good functional status, who's admitted to the hospital with a primary cardiac diagnosis, if that patient has a ventricular fibrillation cardiac arrest, that's among the highest likelihood of good outcomes for any patient. I also think there's a not small group of patients for whom we should recommend against CPR. After we've heard about what's important to them, what their goals are, what their values are, we often hear about goals that are not achievable or certainly wouldn't be achievable if the patient suffered cardiac arrest. So for those patients, when you think that there's an extremely low likelihood of benefit from CPR and a high likelihood of harm, for any other medical intervention with a low likelihood of a good outcome and a high likelihood of a bad outcome, you would recommend against it. I think we should do that for CPR in these situations. And I also think there are situations and there are patients for whom we should not offer CPR. We shouldn't offer CPR to patients who will die imminently or have no chance of surviving CPR to the point of leaving the hospital. I want to give a couple of examples of patients to whom we shouldn't offer CPR. And I'm going to use real-life examples from my practice. So I admitted a patient with upper GI bleed. And as soon as they actually were flown from another hospital, they had failed attempted endoscopic control of bleeding. They had variceal bleeding. And the patient was exsanguinating in our ICU. And we had no means of trying to control that bleeding. And the patient had hemorrhagic shock. Everything we were trying was failing. The patient was bleeding to death. I don't think that's a situation where I go and talk to his family and ask them if we should do CPR when his heart stops because it has no blood in it. I think that's a patient or a family that we should say, here's what's happening, and he's dying, and when he dies, we're not going to try CPR. That wouldn't work. I'm not making an argument in favor of widespread unilateral DNR. The notion that we as physicians should walk around the hospital and just secretly put purple stickers on the charts of patients that shouldn't be resuscitated, which happened at a New York hospital for a decade or more. And I also think the experience in the United Kingdom of widespread unilateral DNR should raise concerns in us. It's not necessarily something, it was something that was much more likely to be applied to poor patients, patients of color, patients who didn't have family. So, but I am saying that there are these situations in which we really shouldn't offer CPR. And I want to talk a little bit about one of the reasons or one of the motivations for not offering CPR when it's not really an option or a reasonable option. There are harms of offering what Gretchen Schwarzy and Mike Nabozny, some of our own surgical colleagues here at UW, called a non-choice choice in a piece published in JAMA IM a couple years ago. So there was a vascular surgery patient who had a ruptured aortic aneurysm, had a failed attempt at control of this ruptured aneurysm in the operating room. Again, this is a patient who's exsanguinating, who's bleeding to death. And in this situation, the team actually approached the patient's wife in the waiting room, explained what was going on, and then said, what should we do if his heart stops? And after some consideration, the patient's wife agreed to make him a DNR. Now, it happens that this patient was actually enrolled in a trial of communication about surgery that Gretchen Schwarzy was running. And so the research team met with this patient's widow some months later, and one of the things she discussed was the guilt that she had about that decision. Yeah, it was probably the right decision, but I still feel like maybe we should have tried CPR. That's just one. I think the harm to the family, again, of placing a burden of a decision where there's really no decision. I want to touch at the very end here on just a couple of other specific situations. So what about people who have a DNR who need to go to the operating room or go to the procedure suite? So there is this notion that DNR orders are automatically suspended for surgery or procedures. This notion persists. This is not an ethically sound process. And many professional societies, including the American College of Surgeons, American Society of Anesthesiologists, recommend against this. But it also, we shouldn't just assume that the DNR remains in effect. There are important reasons to think about cardiac arrest in the peri-procedure or peri-surgical setting very, very differently. There are procedure-related risks that might increase the risk of cardiac arrest. But we know the outcomes of arrest in that setting is actually quite a bit better. So the benefits-harms ratio may be very, very different. So the best policy for these patients is what's described as required reconsideration of the existing DNR order. And the American College of Surgeons describes this as a discussion about the new intraoperative and perioperative risks associated with the procedure, again, touching upon the patient's treatment goals, and describe an approach for potentially life-threatening problems that are consistent with the patient's values. And that might include CPR, even for a patient who's DNR outside of the OR. If this conversation can't be had, of course, the physician has to use her discretion about what the right thing to do in that setting, what the patient would want. So I want to summarize and leave a few minutes for questions. DNR orders developed relatively soon after the widespread implementation of default DNR. In the more than 40 years since DNR orders were developed, there's evidence that they're still not achieving the goals of reducing non-beneficial or unwanted CPR. Improving how DNR is discussed and implemented requires thinking about CPR, talking about CPR as we would any other medical intervention, potential benefits, potential harms. We need to have clarity about what DNR is and is not. We really need to develop the practice of discussing CPR in the context of a patient's values and goals of care. And I want to strongly recommend that we should make recommendations to many of our patients about DNR when appropriate, given the clinical context and situation. Thank you very much. We do have some time for questions.
Thank you very much, Dr. Ehlenbach, for a very informative and, I would say, entertaining grand rounds. The floor is open for these questions. So Dr. Peasley is asking about the DNR/DNR and how
DNR/DNI and how widespread that is. Well, and implied in that question is that there is a problem with this, and let me ask you, do you think this is for patients in whom there's an assumption that DNR means DNI? Yeah. Yeah, I think that's problematic, and one of the reasons that I would argue strongly, as I did, for separating the notion is that, again, intubation for many, many indications is just very, very different than CPR for cardiac arrest in terms of the likelihood of benefits and the likelihood of harms. And I think that if we do a better job of separating them, we avoid that assumption and avoid that confusion. In my role as the vice chair of the ethics committee and one of the ethics consultants, I do occasionally, get a question about a patient who's DNR and has progressively worsening respiratory distress. And does the DNR mean that they shouldn't receive mechanical ventilation? So I think that is a problem. Toby?
No, I'll come listen to you talk about anything. Doesn't really matter what you talk about. This was great.
Thanks, Toby.
What do you think of Angela Valente's video-based approaches to this conversation? He argues that this is too elegant of a conversation for lay physicians to handle. Let's just show a video.
Yes, and actually,
Can you repeat that?
so Dr. Campbell asked about, we know we don't do a great job of this conversation. Maybe it's too tough. Maybe we should put a video on for a patient to see, which has been written about, and actually I believe the NHS has started to implement that idea. I have concerns about that because I think these conversations really require that a patient develops some trust for you as a provider, as a physician, and develops some connection with you. The video can't answer difficult questions that arise. The video can't respond to an emotion that these conversations often engender. But the idea of videos, I'm interested in I think there is a potential use there in the training context, but in terms of turning over these discussions to a video screen makes me uncomfortable. The question was, what if I don't have time to have that larger goals of care conversation? And I think time is really a substantial barrier to this, and one of the reasons that these conversations don't always take place. I do think that initiating the conversation can happen relatively quickly, or at least planting the seed to come back around to. I do think it's important that we develop some strategies, particularly for patients at high risk of decompensation or patients with a really high burden of chronic illness, that we do something to determine whether a patient already has ideas about some of these things like CPR. And that can be done quickly. But time remains a significant barrier. I don't have a great answer for changing that, except that I think these are so incredibly important that I do also think that you can prioritize the patients who are for whom it's most important to have these conversations. Some have advocated we should talk about DNR and CPR with all patients admitted to the hospital or undergoing procedures. That seems very silly to me. I had knee surgery in May. They didn't talk to me about DNR, CPR. I'm glad. That would have seemed ridiculous.
So, but Bill, I have just a quick follow-up to that question. And what do you think the role of our primary care physicians in addressing this up front before the patient is in the hospital, where they actually know the patient well, they know the preferences, instead of leaving it to an ICU team that probably met them only a couple hours earlier?
Yeah, I think there's a couple of issues there. I think one issue is that perhaps the conversations aren't being had, although I think they often are being had in the primary care setting. One systems problem that I think we need to tackle is, how do I know that?
Communication.
How do I know that conversation took place? How do I find that in the electronic health record? I would like to see a standalone area where we can document or link to notes where we include these very incredibly important conversations. But one of the things I do in the ICU is when I'm admitting a patient and and they get their primary care in our health system is that I'm literally doing Control F and searching for CPR, goals, code, right? Trying to find whether these, and sometimes we find them.
We have that available at the VA.
Yeah, so the VA obviously developed a comprehensive way to document the conversation and translate the conversation into orders. Yeah, I think it's important to name that, and I'm often, when we're talking about CPR specifically, I am very explicit that a patient who decides they wouldn't want CPR for cardiac arrest, that decision doesn't affect any other treatment decisions. Not when I'm their doctor. No, yeah.
Well, on that comment, we're going to have to leave it there. Thank you so very much.